The video series Better Disease Management was developed by the Georgia and Oklahoma Academies of Family Physicians as a part of the Go Diabetes Initiative. The Better Disease Management series consists of 7 video vignettes, each outlining best practices in the care of diabetic patients. Please proceed to the registration page for more information on the approved number of prescribed credits for this activity as assigned by the American Academy of Family Physicians and AMA PRA Category 1 credit as assigned by the Georgia Academy of Family Physicians. Upon completion of each video vignette, please return to the Resources video page on the Go Diabetes website to complete the activity evaluation and earn your CME. This activity is supported in part by an educational grant from Sanofi Aventis. We thank you for participating in this online activity and hope that it serves as a valuable educational tool.
One thing I would like for you to be able to do very well, and most primary care physicians I think struggle with this a little bit, be able to distinguish type 1 and type 2 diabetics, okay? First of all, and this is just a little chart, you might find this useful to keep handy. I'm not big into memorizing things, but being able to put your fingers on resources you need at the time you need them I think is important as a physician. The treatment for type 1, it's always insulin. These people need to be on multiple daily injections or on insulin pumps, okay? The era of 1 or 2 injections a day or just basal insulin is way over, okay? So versus type 2 where it's pills plus or minus insulin, okay? Age at onset. Now we always think of type 1, and also just another thing, when you're referring to diabetics, the proper nomenclature is not insulin dependent or non-insulin dependent, it's type 1 or type 2. Type 2s can require insulin, so that's the proper nomenclature. And the reason is because there's a lot of type 2s who require insulin, and it can be, you know, if somebody, you're checking out a patient in the hospital, well, this is a insulin dependent diabetic. What do you mean? I mean, because if it's a type 1, you better know, because if you stop their insulin because they're MPO or whatever, you know, next morning when somebody rounds on them, they'll be in DKA. So make sure that you're doing that in your residency programs when you're taking care of people in the hospital, as well as using that type of nomenclature on your charts. So age at onset, most type 1s are diagnosed as a youth, although about 10% of adults who are diagnosed with type diabetes are actually type 1. So still have your antenna up. When you do see somebody that's in their 20s or 30s or even older, some of those people are actually type 1. It's an autoimmune process that's causing their diabetes. Now, we used to think that only, you know, type 2s happen in adulthood, and we know now that there's increasing prevalence of adolescents and pediatric population developing type 2. However, most type 2s are adults, and you all know that. The things about weight, type 1s, most type 1s are normal body weight or usually not overweight. Most type 2s are overweight. Only about 10% of type 2s are thin, okay? Family history, if somebody has a first-degree relative with type 2 diabetes, their chances are high. So if you have a brother, sister, mother, father with type 2, I always tell people the numbers I've always remembered were like 70%. According to this, it was over 50%. With type 1, about 10% of people with type 1s have a close relative, okay? So family history much more important with type 2. DKA can happen very easily in type 1. Can also happen in type 2s, particularly in Hispanics and African Americans, people who are more insulin resistant. And so just because you have somebody come in with DKA, don't automatically assume that they are type 1 or a type 1, because they may be a type 2 who developed DKA. The blood sugar control is a big guide. So type 1s, very labile. I mean, you can have a blood sugar of 40 and 500 in the same day if you're a type 1, okay? Very easy to happen. If you're a type 2, you'll still see some variation, but not nearly as much. I mean, you might see blood sugars of 100 to 300, but not the same type of labile blood sugars that you see with type 1s. Because type 1 is an autoimmune disease, you can see other autoimmune diseases associated, thyroid disease, for example, or celiac disease, or Addison's disease. There's other things that can be associated. So if you see somebody who's diabetic and has one of those, you ought to at least think in your mind, I wonder if they're type 1. Versus type 2, it's less frequent that you see an autoimmune disease associated with type 2 diabetes. There's antibodies that cause type 1, anti-GAD, islet cell antibodies, and insulin antibodies are prevalent. And you don't see autoantibodies in type 2. C-peptides, not that I used to measure C-peptides quite a bit. I rarely do anymore. But in type 1, it's low when somebody's first diagnosed, and then as they get further into the disease, their C-peptides become undetectable. In type 2s, usually the C-peptides are a little bit high initially, and then they kind of fade off with time. So those are just some clues. Now, I hope you paid attention because we're getting ready to have some questions that we'll see if you can answer the questions. And the little blue box in front of you, hopefully, our audience response system, this is the first time to try it. And so we're going to try out and give you a chance to answer some of these questions. And I'm going to read the case, and at the end, we'll have a chance for you to answer the question. 28-year-old Mexican-American female was noted to have a random glucose of 125 on a chemistry panel obtained as part of an annual health fair by her employer. So she had a random glucose of 125. It doesn't say if it was fasting, but we'll assume it wasn't. She's had no symptoms or no abnormal glucoses before. She had a normal glucose tolerance test when she was pregnant 4 years ago. Her past medical history, negative. Medication, she's on none. Family history, mother and brother have type 2 diabetes, so ding, 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 that goes off. You think, okay, high chance of her developing it. Her mother has a history of retinal laser treatments, proteinuria, and a foot ulcer. Social history, she smokes a pack a day. She and her husband own a convenience store, so you can imagine lots of trips to the soda fountain, you know, making suicides, or what are those drinks you get, you know, wouldn't that be awful? If you had that, you could always get your own soda. Has 2 children, ages 4 and 6. She has frequent yeast infections, so that makes you wonder if she's had a lot of, or some hyperglycemia. Look at the physical exam. You can tell a lot just by simply looking at a patient. Are they type 1 or are they type 2? Look at her waist size. She has a 38-inch waist. Okay, her weight, she's 200 pounds. And her height, she's 64 inches tall, so what's that, 5'4"? And then the other thing that you may not know, skin tags. Skin tags are associated with insulin resistance, aren't they? And so if you see somebody with skin tags, you need to be thinking, this patient has insulin resistance, and they could be developing into a type 2 diabetic, okay? Further exam was normal. Now here are her labs. She had an A1C of 6.3, and she had a 1-hour postprandial glucose of 133. So, is she diabetic? And how would you counsel her? So here's your chance to answer. Dun, 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 dun. Oh, this is cool. All right, so 85% of people said no, 15% of people said yes, and the no's are correct, okay? So she had an A1C of 6.3. New ADA guidelines this year say that if you have an A1C greater than or equal to 6.5, then you can diagnose them with type 2 diabetes. So she's close. She's in a pre-diabetes range for sure. And so the other part of that question is, how would you counsel her? You know, what I would tell her, there's actually been several studies done to look how do you prevent diabetes, and the most effective way is tell them to walk, okay, 150 minutes a week at a minimum. And so I would tell her that, and then we're going to counsel her about diet. We're going to get her to a diabetes educator and to a nutritionist. We're going to, you could consider putting her on medication. Some people might argue that, but medications, for example, like metformin, is not as effective as diet and exercise, okay, at preventing diabetes.